This is my presentation for Nursing 576 Biostatistics course. We'll be taking a look at the role of biostatistics in a health delivery model that's used to care for the chronically ill patients. In wealthy first world nations like the United States, major childhood illnesses are rare. However, chronic disease, particularly in adults and the elderly, are a major concern. Chronic diseases are now the major cause of death and disability in the world. According to the World Health Organization, chronic disease is responsible for 59% of deaths and 46% of the global burden of disease. The prevalence and the cost of the chronic health conditions in the United States have enormous impact on the healthcare system and individuals, often with negative outcomes and consequences. As a nation, we spend a considerable amount of our healthcare dollars on people with chronic conditions. Basic changes in the approach of providing chronic care need to consider how global factors impact health. So the issue is chronic care. There's a need to develop and evaluate more effective models of healthcare, recognizing that the often fragmented, uncoordinated, and efficient current delivery system does not meet the needs of older adults who require care for multiple chronic conditions. Currently, many chronically ill patients and their families experience suboptimal care. This is the chronic care model. It was designed to improve patient health outcomes by transforming the daily care for patients with chronic illnesses from acute and reactive to proactive, planned, and population-based. It was developed by Edward Wagner as a foundation to help practices improve patient health outcomes by changing the routine delivery of ambulatory care through 6 interrelated systems changes that are patient-centered and evidence-based. You can see them here in the top blue portion. The 6 components that are necessary to make these changes include self-management support, decision support, delivery system design, clinical information systems, healthcare organization, and community resources. So guided care is an interdisciplinary model of healthcare that's designed to improve quality of life and effectiveness in health area for persons with multiple comorbidities. So it's a program that incorporates evidence-based processes and patient preferences to attempt to improve outcomes for patients 65 years or older with chronic conditions and complex healthcare needs. It uses best practices in chronic disease management, case management, self-management, lifestyle modification, caregiver education and support, transitional care, and geriatric evaluation and management. It was developed by the Johns Hopkins Bloomberg School of Public Health. It's a program that's provided by a practice-centered registered nurse who works with 2 to 5 primary care providers. She also does home visiting for the client, so it links that clinic to home. The team provides comprehensive, coordinated chronic health care to a panel of about 50 to 60 high-risk older patients. So the study that we're going to take a look at today was done in 2009. It talks about the effects of guided care on the perceived quality of health care for multimorbid older persons. And it takes a look at an 18-month outcome of a cluster randomized controlled trial. So the purpose of the study was to measure the effects of 18 months of guided care on patients' perceptions of the quality of the care they received for their chronic condition. Preliminary data that was done in the first 6 months of this clustered randomized trial indicated that the odds of rating overall chronic care as high quality were actually twice as high in patients who had received guided care compared to patients who had received usual care. And so what this study wanted to look at was after 18 months what had happened. So the study design involved a cluster randomized control trial of guided care in 8 community-based primary care practices in urban and suburban neighborhoods in the Baltimore, Washington, D.C. metropolitan area in 2006. So within the 8 participating practices, 14 teams were identified, each of which consisted of 2 to 5 primary care physicians and their consenting high-risk patients. The study's statistician, blinded by the identities of the teams, randomly allocated each team of physician and their high-risk patients to either guided care teams, so there were 7 of those, or usual care teams, also 7 of those. So in the present analysis, the null hypothesis is that the perception of quality of chronic care will be the same for those receiving usual care and those receiving guided care among multimorbid older patients with complex healthcare problems. The alternative hypothesis is that compared to usual care, 18 months of guided care is associated with higher perceived quality of chronic care among multimorbid older patients with complex healthcare needs. So what they did to measure was taking a look at, they had face-to-face interviews were conducted to assess the participants' baseline socio-demographic characteristics, health and functional status, chronic conditions, and satisfaction with health care. Included in the baseline and 18-month interviews was an instrument that they used called the Patient Assessment of Chronic Illness Care. This assesses patients' perceptions of the quality of the care that they have received for their chronic condition. And then 18-month interviews were conducted by telephone by a supervised professional interviewers who were masked to the group assignment. They used computer-assisted interviewing technology, and they underwent 10% reliability testing. This is a little more on the PASIC tool. So the Patient Assessment of Chronic Illness Care tool is a validated measure of patient experience of chronic care and consisted of 20 questions that inquire about the elements of chronic care received by a patient from his or her healthcare team. Respondents indicate how often during the past 6 months they've experienced each of these 20 elements, and they answer by stating either almost always, most of the time, sometimes, generally not, or almost never. The 20 items constitute an aggregate scale and 5 subscales, which are goal setting, coordination of care, decision support, problem solving, and patient activation. So to test their hypothesis that the quality of care for people who receive guided care exceeds the quality of care for people who receive usual care, they compared the two groups at 18-month PASIC scores. For each respondent, the raw PASIC data, they computed a continuous score for each subscale and for the aggregate PASIC instrument by summing responses of the individual elements and then dividing them by the number of the items in the subscale or instrument. And then to also create corresponding categorical outcome variables, they recoded those continuous scores as either high quality, which was a score of 4 or 5, medium quality, scores greater than or equal to 3 or less than 4, or low quality, scores less than 3. And then to compare with the previous analysis of the PASIC outcomes that was done at 6 months, they created dichotomous variables for high quality, which was considered a score of 4 or 5, and low to medium quality, which was less than 4. To estimate the effect of the group assignment, either guided care or usual care, on quality of care, they constructed a multivariate, linear, and logistic regression model of 18-month PASIC aggregate and subscores. So the multiple regression is the statistical procedure that's used to predict the value of one variable from the value of at least 2 other variables. They also included in the model covariance that adjusted for characteristics that they defined as possible co-founders. Socio-demographic characteristics, age, race, sex, educational level, financial status, their health status, functional ability, the subscale that was on the PASIC scores, and satisfaction with health care. And so these they considered possible covariance, and so they wanted to be able to take a look at those even though the subjects were randomly assigned. And the model also included site indicators to account for clustering, for patients' for example, patients' tendency to resemble more closely patients at their site compared to other sites. So to determine whether the effects of guided care varied according to the quality of care patients were receiving at baseline, they stratified the study participants and constructed a multivariate linear regression model of 18-month PASIC scores and aggregate scores. One set of models were based on data from patients who had rated the quality of their care at baseline as low, and others on data from patients who had rated their quality of care at baseline at medium or high. So where they determined their quality of care prior to starting the study. Low quality was defined for each domain and for aggregate scores. And again, a logistic regression model were also constructed to estimate the effect of the intervention on quality of care among the group who rated quality of their care at low at baseline to see if there were differences there. So 3,692 older patients at high risk were identified through insurance claims. Of these, 2,391 were alive, accessible, and eligible. 904 consented to participate, so this was 37.8%. And after 18 months, 96.5% of the guided care and 94.2% of the usual care participants were alive and eligible to participate in the interview. The two treatment groups, the guided care, which were 485, and the usual care, 419, had similar demographic characteristics and chronic disease burdens at baseline. Where they did differ at the 0.001 level was at marital status, functional status, and quality of care. They also had some differences in finance and satisfaction of care and insurer. The mean quality of care scores of the guided care recipients were higher than the mean scores of the usual care recipients in the aggregate areas and on all 5 PASIC subscales. And then in the linear regression models that adjusted for multiple covariants, 5 of these 6 differences were actually found to be statistically significant at the 0.05 level. 18 months after baseline, the odds that a guided care recipient rated his or her aggregate quality of care as high quality were twice as great. And so you see here, similarly, guided care recipients had significantly greater odds of rating 2 specific elements of their care as high quality. You could see coordination of care and decision support. Although not statistically significant at the 0.05 level, guided care recipients also tended to have greater odds of rating their care as high quality in goal setting, problem solving, and patient activation. And adjusted odds ratios were adjusted for participants' baseline age, race, sex, educational level, financial status, habituation status, PASIC score, satisfaction with healthcare, and practice site. So within each of the 2 subgroups of participants, low baseline quality, medium, or high baseline quality, the effect of guided care on the aggregate 18-month quality of care was significantly positive at the 0.05 level. Of the participants with low scores at baseline, those receiving guided care had nearly twice greater odds to rate the aggregate quality of their care as medium or high compared to those receiving usual care. The results of this study rejected the null hypothesis and accepted the alternative hypothesis that guided care improves important dimensions of the quality of chronic care experienced by multimorbid older persons in the urban suburban areas of Baltimore, Washington, D.C. It was consistent with patients that were rated pre-study as low quality and medium to high quality. The limitations of this study were that only 38% of the patients who were high risk consented to participate. Refusers could have actually been different. For example, they may have had worse health than consenters. And then also the provision of guided care to patients in one team within a practice could have contaminated the care provided to patients in the usual care team within the practice. So it could have influenced the quality of the health care provided to the participants. This ends my presentation for today. I wanted to thank you very much, and I just have a little comic here that talks about the old ways of chronic care and how we need to change how we view these issues and being able to provide care for them. And here are my references. So this concludes the presentation. Thank you very much for listening.